often do not respond to therapy and may really represent a different underlying disease process. So as you think about your patient, and I think as John alluded to in the first section of this talk, think of yourselves as a lawyer who is trying to present a case to a jury or to a judge. You are trying to present this case to the adjudicator and asking what information do I need to give that adjudicator so that they understand what I'm seeing in my patients. So the first, as you've mentioned, is that you document that there has been progression for more than 8 weeks. You need to document where the weakness is. Is it arms and legs? Is it proximal and distal? Is it symmetric or asymmetric? And then where the sensory involvement is and where the reflexes are. So how do we document this in a way that allows the adjudicators to really read your case and to understand what you're seeing? So the first is make sure that all of the exams have dates associated with them. So as we're following along with the records, we can understand the changes that your patient is experiencing. We need to know if the exam was done before they were ever treated, or if they're on therapy, or maybe they took a break from therapy, they're off meds at the present time. That obviously can influence the way that the exam looks in that given day. If there are multiple exams, the more exams that we can see, the better. So for example, there may be patients that presented with a typical phenotype, so proximal and distal weakness, upper and lower extremities, and then treated and responded in all their muscles, but maybe not the distal ankle muscles. Well, that would still be considered a typical phenotype because they have the proximal and distal weakness at the time that they presented. So we need to see as many exams as possible that makes us understand the progression of the patient's changes. That can be documented with MRC scores or any other objective way that you have to show us what is actually the strength. And then understanding the features on the left side of the screen so we can see why you're concluding what the patient's phenotype is and that this is an allowed phenotype. So the more that you present that information in a way which is easily understood by the adjudicators, the more likely the patient is to be included into that study. Now, the second piece of this is documenting whether there was progression over time and how the patient responded to therapy. So there can be cases of CIDP, obviously, that present with a Guillain-Barré-like presentation. So it starts very suddenly. And that is still allowed into the study as long as you document that there was then subsequent progression after the initial increase. So it's very important to really kind of understand not just the onset of the disease, but also that early period of time of progression, whether that's 2 months, 6 months, for us to get a clear picture on how the patient progressed in their initial stages. The more you can provide objective evidence in the notes or in what you write to us about the exam or the NCAT score, the better the adjudicators are to see whether or not the patient clearly had objective improvement. And the reason we emphasize this point so much is that many patients who are given IVIG or even corticosteroids may say that they feel better for a while, but they don't have any real change in their level of function or change in their strength. We don't want patients that have subjective improvement. We need to see that there is objective improvement. And so the people that are reviewing your cases, the adjudicators, are going to look very carefully to say, was there enough evidence in manual muscle testing or MRC scores or NCAT scores that there was an objective improvement with therapy? So it's very important for you to try to document that for us. We also want to know that the response occurred in a reasonable time frame based on the type of therapy. So if someone is given IVIG and they improve over 2, 3, or 4 weeks, that's what we would expect. And so we would then believe that. For example, if the improvement occurred 6 months later, it would be very difficult to tie that improvement to the therapy that they received. So again, understanding that progression, the disease course with the initial therapy is very important. If we are trying to document that the patient has an immune responsive neuropathy, it's also important that if they're given immune modulating therapies, that they don't have any muscle groups that worsen. So if a couple of muscle groups get better, but a couple of muscle groups get worse, that is not really what you expect to see with immune-mediated neuropathies. And it's going to make the adjudicators question whether there really was response to therapy. If a patient has had a period of time when their therapy was stopped, so they stopped their IVIG for a few months, or they tapered off of their prednisone, and they don't relapse after the medication was stopped, we need to understand why you believe then that the patient still has an active disease. So those non-relapses during the course of their therapy is also a very important point for us to think about. Likewise, that we are looking for any evidence that you can provide that there is ongoing disease activity. So if a patient is being tapered off of their steroids and they get worse, or a patient IG, all of this gives us as adjudicators confidence that there is disease activity that's present. And then any relapses that the patient has had, we would like, again, the objective documentation that they got significantly worse, because that becomes very strong evidence that the patient still has an active disease process. So again, you are providing this evidence to us as a jury to try to understand what's going on with your patient. So the way in which you submit those nerve conduction studies is also very important. So the more nerve conduction studies you can submit, the better. You can submit the actual nerve conduction study, ideally including the table and the waveforms. So adjudicators like to look at the waveforms because you can see things like temporal dispersion, which can be strongly suggestive of a demyelinating neuropathy. If there's anything in the study that you want to particularly call attention to, please document that in your submission. Highlight that point so that we're sure that our adjudicators pay attention to that. But if there are more than one nerve conduction study, please also submit that as well. Once we receive the information from the nerve conduction study, we have a group of extractors. And our extractors take the values from your tables or your report and enter it into a calculator. We then have cutoffs based on the EAN criteria that I just showed you. And this calculator will count the number of conduction blocks, abnormal F waves, the conduction velocity slowing, the prolongation of the distal latencies, and see, are there two nerves that fulfill each criteria that would make that nerve conduction study strongly demyelinating? Is there a single nerve that might make it weakly demyelinating? So the adjudicators then know we have to look for that additional information. We will also look for sensory abnormalities, so we need to see the sensory nerve conduction studies in addition to the motor nerve conduction studies. And then the adjudicators review that case, review the calculator and the extractor's information to be sure that everything has been entered correctly. And this really allows very consistent interpretation of nerve conduction studies. We have strict cutoffs for each of these criteria, and 1 point above or 1 point below will either make that study normal or abnormal, but we don't really kind of slide that bar. It is really set for this study. Now, another group of patients that I didn't mention that are also excluded from this study are patients that have IgM paraproteins or patients that have antibodies to the nodopathies. So these patients, again, probably have a somewhat different pathophysiology than the typical CIDP type patients. Again, we know these patients are often refractory to IVIG and steroids. This again further supports the fact that the underlying pathophysiology of these cases may be very different, and therefore they are not included in this study. It's also important, again, in a study to have very strict criteria. And therefore, we've come up with a couple of definitions that will be important for you to understand. We do allow patients with diabetes to be enrolled. But if patients are not well controlled, then they will not be younger. And the definition in this study is going to be a hemoglobin A1C greater than 7%. Anybody greater than 7% will be excluded from the study. The question also comes up, how high is a CSF protein to be considered abnormal? And for this study, we are using greater than 55 milligrams per deciliter as the cutoff to be considered an elevated level of CSF protein. Again, for this study, this would be in the setting of a normal white blood cell count. Once you've provided all of that information to us, we will have two independent blinded adjudicators review that submission. If they review the submission and both adjudicators believe that the patient does have CIDP, that they do have evidence of immune responsiveness and active disease, then the subject will be accepted. If both adjudicators review the case and believe that those criteria are not met, that any one of those individual points does not meet the criteria for this study, then the subject would be denied because both adjudicators had said, no, we don't believe the patient meets the criteria. If the decision is split, meaning one adjudicator finds that the patient is acceptable for the criteria and one adjudicator does not, and as John mentioned in the first part, there's usually a 70 to 80% agreement among adjudicators. Then the case will go to the adjudication committee, and this committee will serve as the tiebreaker or the third adjudicator. Now, there may be cases in which the adjudicator is reviewing the case and has questions about some of the information that's documented or not documented. In that case, you can submit a query, a question back to the site for more information. Or that adjudicator could turn to the adjudication committee and ask for assistance if the criteria is unclear. And this, again, does occur as we've reviewed for other research studies. And the point of the adjudication committee then is that it will review all decisions to make sure that there were no facts that were missed during the adjudication process. The reason that we are reviewing all of the cases is that each individual site does not really have the ability to make a formal appeal. So by asking the adjudication committee to review everything, we're making sure that any information that was entered was accurate, that the adjudicators reviewed all the information and did so correctly, and that the committee believes this patient should either be accepted or not, and then that information will come back to you at the site level. So hopefully that makes this clear. It is a very difficult process, and as John talked about in the beginning, the diagnosis of CIDP is confusing. Trying to understand if patients have active disease can be very difficult, particularly in a patient that you've treated for some time. And for us as the adjudicators, we are really on the outside looking in. So the more information you can provide to us, the better we're going to be able to understand what you're seeing in your patient, and the better we're going to make the right decision about whether we enroll that patient or not. So I will stop there and see if there's any questions that we can answer.
Except I'll be the one answering. I know that was a lot of information, and I know it was a long video for you to have to watch late in the afternoon, so thank you so much for your attention to that. But it is very helpful for you to have a baseline understanding of the process so that you can best ensure that your patients go through the process as smoothly as possible. Does anyone have any questions about the adjudication process for this study? Everything is in a portal. So InCircle has their own portal that you'll be introduced to that has training materials for you, as well as an overview of all the different tabs that you can go through. Many different clinics and hospitals and doctors keep their records in different ways. And so we worked with InCircle when they were designing the portal presentation, facing to the sites to ensure it was flexible enough to collect different ways in which you've collected information on your patients over the years, or from a referring physician who wasn't even your patient for a long time. We've had sites submit patients almost completely in a narrative format where they just typed it out. And then we have other sites that really organize the raw record and submit copies or PDFs. That's what they prefer.
จบแล้วครับ
Obviously,
สำหรับงานของนายกวันนี้
earlier, but I'll keep the reminder here. There's generally 6 pieces of information we need for every patient at a minimum. And that does include
เดี๋
an
ยว
NCS
กลับไป
or
ไลฟ์สดต่อที่บ้าน
nerve
เนาะ
conduction. We
เดี๋ยว
do
วันนี้
consider that a standard of care procedure to any
ใคร
patient
จะเป็น
treating
FC
with a
กระป๋อม
potential
เนาะ
neuromuscular disease like
น้อง
CID.
กระป๋อมมาอยู่กับเราแล้วนะ
So it's expected that you would
เดี๋ยว
already
เราเข้า
have
ไป
that
คุยกัน
done
ที่บ้าน
before you consider this patient to be screened in the study.
โอเคครับเดี๋ยวเราก็ลงไลฟ์กันดีกว่า
May
เดี๋ยว
ICRP ask for
เก็บของ
additional
ขับรถกลับ
information?
บ้านก่อน
Absolutely. They could say,
Yeah,
can
we
you
can
check
come.
your records for this or that? Or did you have blood work didn't quite get to and you or request from another site? We'll wait. It's like